Okay, I think we can begin now. Good evening, everyone. My name is Dr. Mohammed Makkawi, and I'll be the host for today. So, just hold on. So, can you all see my screen?
Yes.
Okay. All right. So, for today, we're going to do first, Dr. Mulham will do for us some interview tips and any question and answers related to it. And then we'll be talking mainly about pulmonary diseases regarding the elderly. First, Dr. Huyam will be talking about age-related pulmonary alterations and common symptoms. Dr. Duaa will be talking about asthma and COPD in the elderly. And Dr. Imtithal will be talking about other pulmonary diseases and conclusion. Then any three case scenarios I'll be doing it, as well as how to present a journal to to New England Journal of Medicine. Okay. So Dr. Mulhim, you can start.
Hello, everyone. I'm not sure if you're able to see my screen. Are you able to see me? Hello?
Yes, we can see you.
Okay, that's good. Hello, everyone. I'm Mulham. I'm currently a palliative and a hospice fellow at University of Buffalo, and I'm a graduate of Khartoum College of Medical Science, or what it used to be called Nasruddin University in Khartoum, Sudan. Since then, I had different experiences overseas as well in the US, including being in the first batch of MSU Research Fellowship, the same group. Very proud to have been in the first batch. I learned a lot from my experience there and utilized a skill set for the next phase in my career as I'm going through it right now. I'm still learning and developing different skill sets. Um, Also, I was a resident at the University of Upstate or SUNY Upstate Medical University, graduated last year. And so currently I'm doing my palliative and hospice, which is a 1 year fellowship. So I believe it's a work in progress for every one of our careers. We keep on developing, we keep on building up. The goal of what I'm going to do right now is to speak about first myself, which I did. The second part is about what we do to develop our CVs during the application, but mostly it's for the next year. But at the same time, what are we doing right now in terms of the season? The most important thing to remember is you did amazing so far. You worked so hard. You need to be happy with the success you did so far because you applied. So that's the first thing you need to remember. You succeeded by applying your application. That's a big step. Now, you need to relax a bit, but at the same time, you need to remember that there are things that some people do to make sure that they attain an interview. If some have already attained an interview, congratulations. If not so far, that's okay. It's too early. Usually it takes about a month or so until you start noticing some interviews or being in the wait list. And I would recommend during this phase to start maybe contacting your friends, your colleagues from the universities you attended, or some you know by the interactions through life or some social networking process. Um, Emailing is important to programs, especially if you know that there is some bond, some friendship, some family member. So you can contact the program director or the program coordinator and let them know that you have somebody there. Sometimes that does help in the interview or to attain an interview. Now, one thing that you can start working on, and I'm gonna look at some tips I place here. So right now, you can also start thinking about the interview process, which is first starting by remembering that you can go through the common questions, the Q&As that everyone will distribute. Probably there is some in the group already. So you need to go through them, prepare your answer, and that's the first step. The second step is finding a group of friends and colleagues you trust, and you're gonna work with them. So you can work on maybe with one or two or three colleagues to improve certain skill set. You notice that there's some problem in terms of a certain answer, you provide a question or an answer, and you listen to the feedback, and accordingly you change your answer depending on the responses. That's very critical to take every point into consideration, but also trying to um, provide feedback for your colleagues, and that's how you develop your skill set. You need to remember that there's a lot of things that are important from the other standpoint. I was in your position a few years back. I understand how it goes. It's very stressful, but it's important to not show those stress during our interview. And that the only way to attain that is by practicing. You need to practice a lot to make sure you actually, so as they say, fake it until you make it. That's a real quote, and you need to do that. So what are the things that are critical and important to make that step easy? So by having a strategy, what are the things you're going to do during the interview? If things go wrong, what are your process in terms of your responses? That's critical. So that you can do during the interview preparation with your colleagues, your friends, and having 2 or 3 on a multiple manner or multiple of sessions would help you to attain that skill set. Now, you need to remember that certain things are important first. What are the type of clothing you're going to wear? So if it should be formal, but you should also practice with your friend or colleague so that your mindset is prepared. So at least 1 day or 2 days ahead, try to wear a suit or present yourself in a setting that it is identical to an interview, which is many would call it a mock interview. So where you would have almost everything identical to what you would have in an interview and practice that. I think that's really important. Now, the background and making sure that you are having a good camera, your audio should be clear. You shouldn't be using a headphone. Pardon me, I'm using a headphone. I'm just driving outside right now. But generally speaking, it should be in a good setting. There should be a good lighting. So that you can't tell unless somebody gives you a feedback on it. So you need to make sure you try your best to have the best lighting, but somebody would say maybe the light is not good. So that's a feedback, you're going to work on it. Or the voice wasn't clear. So then you try to analyze, was it an internet problem? Or was it, let's say, problem with the voice recognition in your computer? So then you switch something else accordingly. So 3 or 4 these things need to be prepared before you have your interview. Then the interview itself, you prepare for it by responding to the question and answers or the Q&As. That's important. But also you need to know your interviewers. So usually they would send you a package with the names of the interviewers, maybe 2 days ahead, sometimes a week ahead, sometimes 2 weeks ahead. You need to go ahead and do your research on your program director, your APD, your program coordinator, as well as every faculty member that you're going to have who's going to interview you. Your goal is to try to figure out a bond between yourself and the interviewer. And you as an interviewee, your goal is to try to understand what is your role and what are the things that you can say and what are the things that you shouldn't say. For instance, you can build up a lot of knowledge just by reading about them and their research projects, and you can build up those bonds, and it formulates your answer in terms of how you're going to frame it, because then it will build up that report that you need, because you want them to remember you. So there is no way that somebody would remember you if it's a vague answer. It needs something to be correlating that human being. Overall, we are human beings, and at times we are biased. And if somebody is, let's say, interested in soccer, and you spoke about soccer, they would probably go and indulge in such a talk. If you know that they are interested in a certain hobby, you go accordingly. But add it at the end of tell me about yourself. If you know that they're interested about a certain research project, you need to mention that project that you had, which is very similar. And you mentioned that you're working currently on a project similar to the project that they worked on in the past. So that those things are critical and important. Remember, when you're preparing your answers, go to the interview. If you, let's say hypothetically, if you have 4 or 5 or 10 interviews, prepare to the interview in front of you. We all know that some programs we like more than others. Don't think about those. Focus on the ones that you feel, or actually the ones that are in front of you. So if you have one interview on Tuesday, work on that. Then think on the second one, because if you're thinking about the second interview already or third, it will make you hate the program that you're going to interview. Your mind is not there, so you're not going to give 100 or 200% effort, because you need to show you are interested in the program, and this would show through such a manner. There are certain things that can be changed after the application. It's few things, probably the photo, I believe also the personal statement. So if you have an update, some would update their personal statement sometimes, but I'd encourage that you provide an email to the program coordinator and director, let them know that I got, let's say hypothetically, you have a research that got published or accepted. Send them an email saying it was pending during the application, but right now it got accepted. Screenshot of the email that you got and send it in the same email that you're sending them with your AAMC ID number. So those things are important. One of the important things also remember that you can start emailing programs. Maybe the majority would do 1 month after, so that you're already not disturbed. Because right now, if you start sending them early, they consider it as a disturbing phase because they're still having gone through the applications. Usually most programs takes about 2 to 3 weeks or sometimes 2 to 4 weeks to start looking at applications. They usually start looking at based on the recommendation, based on the program itself. If it is a high tier or Ivy League, they start looking towards American grads, and then accordingly they go to the list of IMGs and such using filters. If you feel that you're going to be filtered based on a certain factor like age, based on a score, based on other factors, make sure you need to email programs so that they know that you are a unique applicant without mentioning the age or the factors that you think are red flags. Just try them, give them a frank opinion, just that I'm interested in your program because of A or 1, 2, 3. And this is a summary of my CV, which is the things that you think are unique and they are important to that program. Usually there are things like research fellowship, there are teaching experiences, anything that's relevant. If you volunteered in a big facility or an Ivy League facility, and by Ivy League, I'm referring to some programs that are in the top 10 or top 20 in the US. For instance, Johns Hopkins, Mount Sinai, probably it's there. So those big names, Harvard. So if you have correlation or you work in a such facility, even if it is volunteering or research fellowship, mention it. It is important. And if you know somebody who's a big name, try to have that big name contact your program director, because those are important factors because they vouch for you. If somebody vouches for you in a program, usually that's a high points for you, and you might get an interview based on that. Now I'll leave the space so that everyone who feels that they have questions, please feel free to ask me any question you would like. Probably starting the last few days, Dr. Nader included me to be mentor in Team Walnut. So if anyone here today, present today, is in the Team Walnut, please feel free to contact me anytime for any advice, any mentorship questions. But even if it is for anyone in the group, feel free to contact me at any time. So I'll try to provide you the best advice or tips from my experiences. And regarding research projects, I do work on research projects from time to time. Currently, I'm stopping due to different things that I'm working on, but probably I'm going to be back to working on projects in December or January. Anyone who's interested in projects, let me know. Usually I share my thought process during those projects, and usually it's smaller projects. I would say probably case reports, retrospective studies, articles. So almost in every 6 months interval, I work on few days or few weeks on a project. I do have a team already assigned from the last few years that we work on projects, but if anyone is interested, I'm very willing to share the thought process. How do we work in maybe a middle tier or a high tier university program? What are our thought process and how we can get a project starting from the question itself being a hot topic into transitioning into the next phase, which is actually working on it and dividing the project, which is part of the leadership. So part of your job as a researcher, if you are the primary, to distribute the project into your team members, and then trying to also having the deadline on when you're going to submit it and when are you going to improve the project so that it has the last phases of it, starting with the title and every aspect with the conclusion as well, and choosing the journal that you're going to send it to. So all the things, hopefully I'll be able to discuss while we are indulged in a project if someone is interested, but also specifically for Team Walnut, because I'm going to be your mentor. Please feel free, if you have a project, let me know. I will try to assist you in those projects. And if you're interested in the project I'm going to work on in the future, just let me know. I will include your name so that we can discuss that during those circumstances. Other than that, I'll leave the mic for Mohammed, so Dr. Mohammed, so I can work on continuing the process of today's agenda. But if anyone is having any questions, please feel free to ask. And thank you.
Thank you very much, Mulham, for this great information and tips. As you know, all of us now at this time is the interview period, so yeah, a lot of people will have a lot of questions. So if you have any questions, please post them. Dr. Mulham will be ready. Will be here to answer your questions. Okay. All right. Then let's go. Let's move on. I think we can start our presentation for today. Okay. My team will be talking about respiratory diseases and disorders. Okay. Is Dr. Huyam here?
Yeah, I'm ready, Dr. Mohammed. Can you share the
Okay.
screen?
Yes, sure. I'll
Okay.
share the screen right now.
As said, Dr. Mohammed, we are talking, our presentation is about respiratory diseases and disorders. The objectives is to know and understand. The objectives is to know and understand how to evaluate common respiratory symptoms, dyspnea, like dyspnea, chronic cough, and wheezing. Then we are discuss the 5 A's of helping patients to quit smoking. Also, we are talking about how to recognize and treat the major pulmonary diseases and disorders in the older patients. And the last one is a decision making about the mechanical ventilation at the end of life. Next. The topic covered age-related pulmonary alteration, common respiratory complaint and symptoms, major pulmonary disease in the older person, intensive care of critically 3. I'm talking about the age-relating pulmonary alteration. Age-relating pulmonary alteration includes several key structure and functional change in the respiratory system that reduce the lung efficiency and the overall respiratory function. The first one is reduce the airway size and the alveolar sac. It becomes shallow, so that because of alteration in connective tissue. The alteration in the connective tissue lead to reduce the airway size and the alveolar sac become shallow. Also, the chest wall compliance is reduced as the consequence of calcification of the costal cartilage and the arthritic change in the costal vertebral joint, so that it affecting also in the respiratory function. The intercostal muscles, it become atrophy, and reduction in the diaphragmatic strength, it become 25%. According to the researcher, that's all of this process result in decline of the forced vital capacity and forced expiratory volume in the first second. It become 25 to 30 milliliter per year in the non-smoker older patient, and 60 to 70 milliliter per year in the smoker patient. Next slide, please.
Yes. This is the next slide. Next slide. Okay.
Yeah. No. Yeah. Yes. This is this one. There is difficulties in the recognizing respiratory systems, like in recognize of respiratory systems. This because is a common misperception is that older people tend to overestimate it or exaggerated respiratory system. However, research indicated that the older adult often underreported their symptoms because of aging or decline in the cognition of older patients. This underreporting might be due to reduce the perception of the symptoms or acceptance of the symptoms as a part of aging, or the cognitive decline, making early diagnosis more difficult. For example, dyspnea may go undiagnosis until advanced disease is evident. This is partly due to the fact dyspnea is blamed on the conditioning and age. Also, we are seeing the older people often have more than one explanation for their problems. For example, dyspnea, cough, and wheezing may be overlap. In addition to that, these causes may include a combination of disease such as asthma or emphysema, obstructive sleep apnea, and heart failure, and gastroesophageal reflux disease. Okay. Any questions? Okay. We are talking about rhinosinusitis. As you know, rhinosinusitis refers to the inflammation of the nasal cavity and paranasal sinus. The diagnosis and treatment of it generally don't vary by the age, different with age. It can be divided on acute, which can be at least the 2 to 4 weeks, or can be the second one is subacute, which persists between 4 to 12 weeks, and the third one is a chronic rhinosinusitis, which persists for up to 12 weeks. The treatment of the bacterial rhinosinusitis with analgesic and saline irrigation, adding to antibiotic if the symptoms beyond 7 days or worsen. We cannot use the antibiotic in the early stage of the mild diseases because it lead to harmful, and that's it is misuse of antibiotic. The chronic rhinosinusitis is treated with a topical agent and a saline irrigation. But the allergic one is treated by avoid the allergen that's and use the topical steroid, nasal steroid, or just use the topical nasal steroid to overlap or to decrease and control the symptoms. Next. Dyspnea, which defined as the shortness of breath, is a common symptom that may result from the several underlying conditions, such as COPD, cardiac disease, asthma, intestinal deconditioning. It can not related, or it does not necessarily correlated with the oxygenation or pulmonary function test. The diagnosis is dependent on the history and the physical examination. Which the test and the treatment may be the history and physical examination. It helps in determine which the test and the treatment may be most effective. The patient description of their dyspnea can provide clue about the underlying causes. For example, when the patient say the term of heavy, that's may suggest cardiac issues or deconditioning. When the patient describing the sensation as tight, that can that indicated it for angina or asthma. The presence of the significant weight loss or conditional symptoms like fever and night sweating that could suggest other diseases such malignancy and tuberculosis. We are talking about next chronic cough. Chronic cough, it's benign cause, has benign cause. The most common causes for it is postnasal drip, asthma, gastroesophageal reduced disease. The cause can treat the chronic cough. The combination of this condition may contribute so the treatment for the multiple causes may be working when the signal therapies are ineffective. Any question in these slides? Wheezing is the high-pitched whistling sound that occurs during breathing, often associated with narrow airway. The common causes of it is asthma, postnasal drip. Also pulmonary edema, which called the cardiac asthma. It can be associated with heart failure. Can be give me the wheezing because the fluid accumulated in the lung due to congestive heart failure led to breathing on examination. Also, airway hyper responsiveness from the chronic bronchitis is not uncommon in the elder patient with a history of wheezing and sputum and tobacco use.
Okay, thank you very much, Dr. Huyam, for this
Any
presentation. So, you have anybody? If you have any questions, you can post it in the chat.
Okay. Thank you very much, Dr. Mohammed, for giving me this opportunity.
Thank you very much for this presentation. So we can move on to the next topic. Major pulmonary diseases in older person. Okay. So can you start?
Can you hear me?
Yes, we can hear you.
Okay, good morning, good afternoon, and good evening, everyone. I hope you are all good and doing well. I'm Dr. Duaa and I have been graduated from University of Khartoum. Today, I will be talking about asthma and chronic obstructive pulmonary disease in elderly. So as we know, the older persons be prone for major pulmonary diseases, and these are asthma, chronic obstructive pulmonary disease, also like obstructive sleep apnea, idiopathic pulmonary fibrosis, pulmonary thromboembolism, pneumonia, and lung cancer. Next, please. We are going to start by asthma. 5% and around 5 to 10% of people who are 65 years of age or more met the criteria for obstruction and bronchial hyperactivity. But unfortunately, asthma in older adults is under recognition and under treatment. And that's led most of the deaths, or around 50% of those people, are those who are 65 years of age or more because of the under recognition and the under treatment. Next, please. For treating asthma in all people, we commonly depend on the inhaled corticosteroids and other controller drugs like leukotriene receptor antagonist, but we should start with the lowest effective dose. For the beta agonist, we mainly use these as reliever medication. And of note here, most physician instruct for the proper use of the PEF monitoring because the older persons have decreased perception for bronchoconstriction. Here we can stop and discuss a little bit for the instruction. So the physician should instruct the patient in correct activation of the inhaled device and observe the patient actually use it. Neurological, muscular, and arthritic diseases can lead to the suboptimal timing and discoordination in the actuation of the inhaled or the inhaler. counsel the patient about raising the oropharynx to avoid the thrush. In older people, theophylline is fraught with adverse effects and drug reactions or interactions and should be considered third-line drug to be used only as a once daily medication in the evening for severe asthma or COPD, targeting a serum level of 10 to 12 milligrams per deciliter if tolerated. For the OCS, which is the oral corticosteroids, are discussed in the next sections for the COPD. Also, when using the beta agonists, we should also concern about the side effects of these, which are the hypokalemia or the QT changes that we could find them on the ECGs. So we have to warn the patients about the side effects of this medication. Okay. Here we are going to discuss the COPD epidemiology. Okay. In US, most people with COPD, they are maybe a smoker, because we know that COPD is related to smoking, and they are numerous. They may be like 5 million, or sorry, it's 15 million people in the US. And this is believed to be the fourth most common cause of death after heart disease, cancer, and stroke. For the prevalence and the mortality rate, they are increasing, especially in older people. So the mortality and the morbidity from COPD accounts for more than $15 billion per year in US medical care expenditure, mainly due to hospitalization. Next, please. Okay, for diagnosing COPD, we rely on many things: symptoms, findings in clinical examination, the imaging as well. Sorry, can you make yourself unmuted? COPD diagnosis. For COPD diagnosis, we rely in many things. For example, wheezing, because most obstructive diseases, we find on them wheezing. Also, we can find many findings on the examination as well as the imaging. For example, we can find the parallel chest, shaped chest on the X-ray, hyperresonant sounds on the percussion, force expiratory time more than 9 seconds. So all these are the predicators for COPD. Next, please. We have here the GOLD guidelines for COPD. GOLD means it's an abbreviation for the Global Initiative for Chronic Obstructive Lung Disease. And for the GOLD guidelines for the COPD, we have key factors for diagnosing COPD. We mainly rely on the symptoms and the risk factors. Here in the symptoms, we have dyspnea, chronic cough, sputum production. For the dyspnea in COPD, it's a progressive symptom that may get worse, and it may worse with exercise as well. It is persistent over the day. And it is described as increased effort to breathe, heaviness, air hunger, gasping. For the chronic cough, it is intermittent and non-productive. For the sputum production, any pattern could be with COPD. For the risk factors, as I mentioned before, could be with smokers, also with those who work in on those areas or industrial places, also for those who usually cook with heat, fuel, and smoke at home, I mean. Next, please. Also, we with the GOLD guidelines, depending on the spirometer, we classify the COPD into 4 main classifications. We depend on the force expiratory volume in the first second over the force vital capacity, which should be less than 70. But note here, some experts, they said the force expiratory volume over the force vital capacity on those who are more than 70 years of age should be less than 65. Why that? This is because of the changes that may happen on the structure of the airways of those people during the aging process. So here we classify the COPD into four main classes: the mild, the moderate, severe, the very severe form. And this is depend on the ratio. If it is 80% or more, this is going to be the mild. If it is less than 80, but we could say it's 50%, but less than 80%, this is going to be the moderate. If it is 30% or more, but less than 50%, this is going to be the severe form. Very severe form is being less than 30% for the forced expiratory volume, or being forced expiratory volume less than 50% with a chronic respiratory failure. Next, please. Okay. Here we are going to talk about the 5 A's created by the Agency for Healthcare Policy and Research. The 5 A's is concerning about counseling your patient. If he is a smoker patient, you should advise him to quit smoking, because when he quit smoking, that's going to improve his lung function. So what are the 5 A's? The 5 A's are asking the patient about using tobacco at everyday office visit, assessing readiness to quit, advise patient to quit, assist patient to quit, or assessing the patient in the quit attempt with aids such as local cessation, giving local cessation programs, and giving him pharmacological agents like bupropion or nicotine replacement, arranging both a quit date, follow-up visits, or even contact to discuss the quit attempt. Next, please. Okay, for COPD therapy, as I mentioned, you should classify your patient into mild, moderate, severe, or even very severe so as to give him the appropriate therapy. For those who have a mild COPD, you should use a short-acting beta-2 agonist when needed. For the moderate one, you use regular treatment with one or more bronchodilators, long-acting bronchodilators if needed for added benefit, or if there is 2 or more exacerbation per year. And also you have to consider the rehab. For the severe COPD, you have to use the regular treatment with one or more bronchodilators. You have to use also the inhaled steroids, or if significant symptoms and lung function response, or if there is a 2 or more exacerbation per year. And also you have to consider the rehabilitation. For the very severe COPD, you have to use the regular treatment, one or more inhaled steroids. If significant symptoms and lung function response, if you have any complications, you have to treat them as well. And you can also consider the long-term oxygen therapy. So beside all these medication, you have to add the oxygen therapy, and on this you have to depend on the PO2. If it is less than 55, then you have to consider the oxygen therapy, but not more like 15 hours per day. Next, please. Also, beside the oxygen therapy, you have to advise your patient and to educate him about the respiratory therapy, about having exercise. Here, also they said around 40% of COPD patient, they may get psychiatric issues like major depression and anxiety. That anxiety may let them to seek the help to ER and may let them to be more prone for more admissions to hospital. Thank you so much. I hope you are enjoying our session. And now I will give the mic to Dr. Imtithal.
Thank you very much. Now Dr. Imtithal will continue from here.
Okay. Hi, everyone. I'm just checking, is my voice very clear before I start?
Yes, we can hear you very well.
Okay, thank you. Thank you so much. Okay, my name is Imtithal Ahmed. I'm graduated from University of Khartoum, Sudan. So I'm gonna continue on the same topic, just briefly, I'm gonna talk about other pulmonary disease. I will start with obstructive sleep apnea. So as we know, like obesity, it's like the most problem that showing in US air recently. So this is like a big warrant for this this kind of pulmonary disease, which is obstructive sleep apnea. So it is a really life-threatening, and it's caused like a potential risk for cardiovascular problems, like a stroke, myocardial infarction, and definitely all these increased mortality rate 3 times the normal rate. So, and this kind of disease, it's often like undiagnosed, and therefore it's not treated early from the early sign, because all the sign of the OSA, it's general symptoms like morning headache, fatigue, and most of the people, they think this is like a normal symptoms. So especially in the elderly, when they have these symptoms, they associate it to the other comorbidity or the other disease that they have. So most probably they will find it on a late stage. Next, please. So I will talk about the treatment, and most of the treatment for the OSA, it's lifestyle modification, like weight loss, if the cause is the obesity, lifestyle modification in avoiding alcohol, and minimize the sedative medication, especially elderly patients. They have issues in their muscle tone. It's decreasing by age. So we have to revise their medication regularly and minimize this type of medication. And we advise them to sleep on one side or upright position for their safety at night, and correction of any metabolic disorder if they have, for example, hypothyroidism. And definitely the first option is the CPAP, other than or beside the lifestyle modification. The next disease that I'm going to talk about is the idiopathic pulmonary fibrosis, and it's a progressive disease. So the median survival is very short. It's about 3 to 5 years. Normal presentation, it's come like suddenly or insidious. So they have dyspnea, cough. The late presentation, maybe they have like a sign or symptoms like clubbing, and this is often prominent on finding in the pulmonary fibrosis more than the other pulmonary disease like emphysema. We commonly treat the patient with idiopathic pulmonary fibrosis with oral corticosteroid, but only 10% to 20% of the patients that respond to this oral steroid. And of course, we have the adverse effect of the steroids. This is often prominent. the using of regular like inhaler steroid is not showing that it's useful for this for the pulmonary fibrosis. So we use the oral steroid when they have exacerbation or they have really severe symptoms. And early referral to subspecialist, to like a pulmonologist for follow-up. And because as I said, it's a progressive disease. So this is the key for treatment. We have to advise the patient to go to and follow up with the pulmonologist for further survey. Next, please. My third one is the pulmonary embolism. The incidence triples from age 65 to 90, and more than the 70 years, they have like the risk factor. So, and because like most of the elderly, they have other comorbidities, um, uh, having like issue in their circulation, and most of them they limited mobilization. So that make them they have very high risk to get pulmonary embolism. And some of them, because in pulmonary embolism, it can be asymptomatic, and that let them miss the diagnosis most of the time. Blood gas is normal in 10 to 20% of this patient, and this is like make it harder for the physician to get it in early stage. And the diagnostic workup at the same as the younger patient. So it's the same thing. There is no difference between young and all elder patient in the diagnostic workup. We do CT, we do blood workup. 10% they have recurrent rate within 1 year. That's why we use anticoagulation for really long time, maybe up to 6 months. Next, please. Anticoagulation is guided by the same principle as in younger adults. In older patients, maybe even more important to achieve therapeutic level of heparinization quickly. We use a low molecular weight heparin, while achieving anticoagulation with warfarin is supported by well-designed trials. Allow overlap approximately 1 to 3 days between heparin use and adequate warfarin therapy, and we keep the INR range target 2 to 3. In most cases, anticoagulant therapy should continue for at least 6 months, as I said. Next, please. Okay, so I'm going to talk about the intensive care of the critically ill patient. So the support study show physician error rate in approximate the patient, preference for mechanical ventilation, 36% for patient less than 50 years, and 79% of patients with more than 80%. So this is a big percent for the elderly patient. Physicians should be more consistent in attempts to elicit patient preference for DNR orders. So it's very good to talk to the patient about any possibility for ventilation, intubation, and DNR order as early as you can. So because they have a high rate of mortality. The decision to use mechanical ventilation should not be based on age only. You have to take it like as a whole, the severity of the symptoms and his age too, and the comorbidity. Next, please. Unlike the general medical ICU population, patients with acute lung injury and ARDS appear to have higher mortality with advancing age. Acute lung injury patients require nearly twice as long to be liberated from the ventilator, and the comorbidity often contribute to death in acute lung injury. Cognitive decline often dramatically worsens after ICU stay and becomes a major threat to quality of life. On a study of 851 patients receiving mechanical ventilation, they found that 63% were successfully liberated and 17% died while receiving the mechanical ventilation, and 20% have mechanical ventilation withdrawn. So this is a big percent for mortality, and that's why we encourage to discuss all the possibility of the option treatment with the patient. The AMA recommend a standardized or fair process rather than a strict definition of fertility. Rather than chronological age alone, fertility decision should be based on factors such as the clinical efficacy of treatment, likelihood of mortality, and subsequent quality of life. Next, please. Okay, on a summary, I'm gonna wrap all of these, saying with age, there is a decline in forced vital capacity, FEV1, and the partial arterial oxygen, while the AA gradient increase. And 5 to 10% of people more than 65 years meet the criteria for asthma, and smoking cessation may slow the decline in the lung function at any age. So this is the key treatment for most of the pulmonary disease. Next, please. I think I have to transfer the mic to my next colleague, Dr. Mohammed.
Hello, everyone. So just a bit of a summary. So most patients with COPD, they usually don't derive much benefit from routine inhaled steroids, but a brief course could help of systemic steroids so they can reduce the duration of an acute exacerbation. And older patients recover pulmonary physiology at the same rate as younger, but some disease states can usually prolong it and may require a longer time to be liberated from the ventilator. Okay.
Thank you.
So thank you very much. So let's do some cases. Okay. So we have a 72-year-old man. He comes to the office for dyspnea that progressed slowly over 6 years. He complains of daily non-productive cough and wheeze and decreased activity. He has a past medical history of exacerbation of COPD, which required prednisone, but otherwise he was not hospitalized or gone to the emergency room. He quit smoking 3 months ago. So on examination, his temperature is 36, blood pressure 145/85, heart rate 96, and respiratory rate 22. He has no accessory muscle use, and bibasal crackles are audible, and exhalation is slightly prolonged. Cardio exam is normal. There is some trace ankle edema, but no cyanosis and clubbing. And oxygen saturation at room air is 93%. Just the X-ray showed the hyperinflated lungs. Okay. Pulmonary function tests were done for this patient, which showed FVC 85% of predicted, FEV1 60%, and FEV1 over FVC ratio 60%. After treatment with the bronchodilator, his FEV1 increased by 11%, and FVC increases by 10%. So this is the question. In addition, he's already continuing albuterol. Which of the following is the most appropriate treatment at this time? So you can just post your answers in the chat. Okay, any answers in the chat? Okay, we have B. Any others? Okay, so actually the answer is okay, we have a C. Okay, I think if we summarize it a bit quickly, it will help. So FVC is 85%, FEV1 is 60%, and FEV1 over FVC is 60%. When given bronchodilator, it has a mild increase by 11% and FVC by 10%. Okay, so actually the answer is D, tiotropium. Well, for this patient, he has actually a moderate increase, a moderate COPD exacerbation, since his FEV1 is 60%. So he will need to, you have to give him another long-acting bronchodilator, which is tiotropium. It's one of the long-acting muscarinic antagonist, and is given once every 24 hours. All right. Okay. So we'll go for the next question. We have a 75-year-old man. He's evaluated for sudden onset shortness of breath, sharp pleuritic left-sided chest pain, and productive cough of blood-tinged sputum. So I think from the history, we already have an idea of what could it be. Yeah, the elective hip replacement 6 days ago, and he's been wearing pneumatic compression devices on both legs. He has a 20-year history of COPD, and he's taking a PPI for duodenal ulcer 2 weeks ago, and albuterol as needed. Okay, his temperature 38, blood pressure 165 over 90, heart rate 110, and respiratory rate 26. There is no accessory muscle use, and there is slight expiratory wheezing. There is no jugular venous distension, and the S4 is heard and audible. Okay. The abdomen is soft with no masses or hepatosplenomegaly, no cyanosis, clubbing, edema, or sigh or cough pain. WBC count is 13.8 with an 85% polymorphonuclear cells and 6% bands, and D dimer is less than 500 nanograms. Okay. So an ABG was done. His pH is 7.48, and PaO2 is 70, and PaCO2 is 30, which is a bit low. An ECG showed sinus tachycardia, and chest X-ray showed lower lobe atelectasis or infiltrate. DQ scan was done and showed a low probability for pulmonary embolism. Bilateral Doppler was done for the legs and it showed no evidence of deep vein thrombosis. So what would be the next appropriate step for this patient? So he has strong symptomology regarding pulmonary embolism, which could be leads to pulmonary embolism. What would be the next step for the patient? So can you just put your answers in the chat box? Okay, we have a C. Anybody else? Okay, we have E. Okay. Well, the answer is actually E. We're going to do a CT angio for this patient because even though his VQ scan showed low probability and his Doppler was negative, we still it does not rule out pulmonary embolism. And for high WBC, it actually can be explained from the pulmonary embolism by itself can raise the white blood cells and also can cause fever. It is a common cause of fever in hospitalized patients. Hope it's clear. All right. So we can go to the next case. We have a 70-year-old retired male man. He's presenting because of difficulty climbing one flight of stairs, and he has dyspnea on exertion. that has progressed slowly over 5 years and has occasional wheezes. Minimally productive cough in the morning, but for years, but no chest pain or discomfort. He has a 50 years back smoking, and he still smokes. So his temperature is 36, blood pressure 115/75, heart rate 98, respiratory rate 22. Okay, there is no accessory muscle use, and bivasal crackles are audible. Cardiac and abdomen exams are normal. There is trace peripheral edema and mild clubbing. Chest X-ray is normal, and pulmonary function tests were done, and which showed FVC is 65% of predicted, FEV1 is 70% of predicted, and FEV1 over FVC ratio is 75%. After bronchodilation, FEV1 is increased by 9 and FVC is increased by 8. So what is the most likely cause of his dyspnea? So you can put your answers in the chat box. We have a B. Anybody else? Okay. So actually the answer is C. He has fibrosis because of his pulmonary function test. Showed that he has 65% FVC and FEV1 is 70%, and the ratio is almost normal 75%. So this points towards pulmonary fibrosis. That is one of the reasons why it's difficult to diagnose this elderly, because there's an overlap between normal physiology because of his age and pulmonary fibrosis. Okay, so that's all for this presentation. Thank you very much. Okay, so we'll move on to the next presentation. Right, thank you. So we'll move on to the next presentation. It's about how to submit a manuscript to New England Journal of Medicine. Okay. So first we're going to give a brief understanding about the journal. So first we have some things to do overview. There are some important things which we have to cover today about how to understand about preparation, how to prepare a paper, and submission process, the cover letter, and supporting materials if this is required. Okay. So so what do we need from so what structure should we follow? Usually the main required structure is as given here. Just we have to have a good abstract, an introduction about the topic, the methodology regarding it, and the results, and then a brief discussion about the results, and finally the references. Okay? It is very important that we have to be very clear and concise, and we should have an objective writing. Okay? Then ethical considerations depends on the study itself, especially if it's prospective, and randomized clinical trials. So we have some ethical guidelines that we have to follow. It depends on the study and as well as the ethical board committee in which it is based on. So here, what we're going to do, it should be followed when conducting and reporting research, such as informed consent and protection of privacy. And it's important to report any research findings accurately and honestly. Okay. So the NEJM actually has a particular formatting guidelines regarding the font and spacing. And they also have templates which you can download and use them as needed. Okay. So in the submission process, once you open the website, like in the screenshot here, you can find that you can make your own account here. Then if you go to the side, you will find submit new paper, submit, and over there you can submit your paper. Okay, and also put on all the required information and documents. Okay. Also, one of the more important papers that should be submitted is the cover letter. So the cover letter actually is the main thing that they look at, because it gives a good impression. A good cover letter can help with the approval process. Okay, mainly composed of title, summary, and the significance of this study, as well as the author contributions. Okay, some tips that the title should have a good and should be eye-catching and should give a good overall idea about the study. And the summary should run through all the methodology and literature review quickly and results. Okay, and the author contribution, which each author has contributed. There is some certain criteria that should be fulfilled in order for them to be part of it. Okay. Then in some papers we require additional materials that should be uploaded, such as the conflict of interest statements or copyright permissions. Usually you will find them in randomized control trials. You will require these documents to be uploaded as well. And this can be prepared again. They also have guidelines in the website on what is required, and depending on your study, you may need or may not need them. Okay. So once you submit your paper, it will undergo peer review process, usually undergone by at least 2 peer reviewers. And some studies, such as original research articles and some review articles, they also undergo dedicated statistical review to ensure that the conclusions drawn are supported by the data provided. Okay. Also, additional outside specific peer review may be sought if there is an area where editors feel that the peer review was inadequate. Okay. So what is the potential outcomes? It can be either be accepted or revised, or it could be rejected. Okay. So if it is in the class that if it is revised, usually when they return it to you, they will give you comments on each section that needs to be revised. So we'll have to see the comment and ensure and answer every issues that happened during it. Okay, and it's important to make sure that every revision is made according to what they wish. Okay. So once if it gets approved, it goes to the publication review. So before it gets published, they usually undergo a few steps, such as copy editing, in which the paper itself may be changed in order to have a higher quality and better readability, and proofreading to see if there is any mistakes and to ensure that it's flawless. Sometimes there are some papers they undergo something known as embargo periods, where within at least for around 6 to 12 months, not the entire paper will be published, but only the title, abstract, and the citation info. And once the embargo period is over, the entire paper will be released to the public. Okay, that is all. Thank you very much for your time and presentation. I hope you have enjoyed your time here with us. Okay. Do you have any questions, anything you would like to ask? Okay, so we have reached the end of the presentation for today. Thank you very much for all of your time. I hope you have enjoyed it, and hope we see you again next week. Okay, thank you very much.
Thank you, Dr. Muhammad. Thank you so much.
Thank you, everyone, for the presentation. It was really great to be here. Thank you, Dr. Muhammad, for narrating everything. Appreciate it, everything. If there's any question, please feel free to contact me in my emails. Thank you, everyone.
Thank you.
Thank you very much. Thank you all.